we're gonna go ahead and get started. We got about an hour talk here. So today we're gonna talk about non-contact anterior cruciate ligament injury. We're gonna review a little bit of the anatomy, the kinematics, the risks of causing ACL injury, a little bit about rehab, return to play. So sit back and enjoy. Today's presentation has been brought to you by Sam Bradford's knee. This is his first ACL injury. This is his second ACL injury. That's the ref, what I assume is taunting him, which I think is a 15-yard penalty. So have fun with him. Unless Tebow plays, I'm going to be a bandwagon Seahawks fan next year. So enjoy, Eagles. So introduction. The injury to the anterior cruciate ligaments is one of the most devastating and frequent injuries we see in the knee. If it's an you or me, it's painful, it's frustrating, it's extremely limiting to our activities and to our kind of ability to do anything we want to do athletically. In a professional athlete, it can be career threatening. Either case, it's bad news. So some of the objectives of what we're going to get out of today's lecture, hopefully, I'm going to review the knee and ACL anatomy and function, elucidate lower limb kinematics, how it pertains to the ACL, educate you on predisposing factors of non-contact ACL injury, shed light on some gender differences with regards to it, discuss some treatment options, briefly overview the rehabilitation and return to play, and then propose a little bit of ACL prevention theory. So ACL injuries can be broadly divided into two separate categories: non-contact, contact. Here you see Navarro Bowman getting rolled up on. That's an unhappy knee. That's a contact injury. On the other side, you see Robert Griffin III during that playoff game that he never should have been in, when he dropped the fumble the snap and reached down to plant to pick up the snap, and his knee just buckled on him completely. Trey, which is more common, contact or non-contact? Contact. It's non-contact. Good, exactly. About 70%. Right? So it's actually much more common, which is why we're having this talk today. There's a lot more research into it. So let's talk a little bit about epidemiology. Annual reconstruction costs in the United States of ACL injuries, including therapy and otherwise, is about $2 billion a year. If you injure yours, it's a conservative cost to you of somewhere between $17,000 and $25,000. The average time for reconstruction to return to play is somewhere around 6 to 8 months. They occur most generally in the active population. We say active population because they're the ones that are participating in the sports, in the high-risk activities. That 15 to 25-year-old range is the most common. The next is like the 25 to 45. So really that 15 to 45-year-old range is your most common injury kind of gap. And again, it's because they're the ones that are participating in sports and at a level high enough that they're putting themselves at risk. Annually in the United States, about 200,000 ACL injuries a year. That's roughly 1 in 3,000 people. That number is probably hugely underreported. There are registries that exist for reporting ACLs. They're very good and very strict in the NCAA and professional levels, but in your youth leagues, your high school leagues, your cross-country runners, your recreational athletes, it's not nearly as reported. The NCAA has a system we'll talk about. They've been probably the best at recording these. They've been recording all injuries since 1988, and a lot of the data for incidents comes from their system. Males, way more injuries at the ACL than females, non-contact, okay, by a huge gap. However, females have a much higher risk of having an ACL, non-contact ACL injury than do males. So the numbers, far more numbers of ACL injuries in men, but because there are more athletes, there are more male athletes playing sports, so there's a higher likelihood. But females have risk factors that predispose them to injury, and they end up having a higher incidence of these. So football accounts for about 53% of all ACL injuries. The incident ratio, though, is only 0.13 per 1,000 athletic exposures. And then athletic exposure is defined as any time a player, an athlete, practices or steps on a field for practice or steps on a field for a game. As opposed to that, female gymnasts, which is the highest risk factor for ACL injury in all sports, male or female, has a 0.39 incident ratio. So that makes it the most dangerous. The NCAA surveillance system we talked about since 1988 has been keeping tabs on all this data. They've recorded these, and this was released in 2012. So this is some incident ratios since 1988 between some of the kind of major players in ACL injuries, between male and female. You can see that across the board, females in sports that have equal matching, equal gear, equal risk, they have a higher incidence. Lacrosse, almost the same. I don't know why. No one knows why. Maybe it's giant sticks. Maybe sticks are protective. So why those sports? Why is it those sports that are highest risk, along with alpine ski, which is a huge risk too? I didn't mention it up there. I'm not sure why. It's because these sports require the high-risk maneuvers. These high-risk maneuvers are all focused around really limb deceleration or body deceleration. Some of those that really do, the maneuvers that really cause a lot of that deceleration, landing from jumping, planting, cutting, pivoting, okay? Which is why those sports that we just saw are ones that end up tearing most ACLs. Another high-risk maneuver I'd like to present to you is decelerating. Here we have Martin Gramatica, 1990, who kicks the game-winning field goal, jumps, lands, blows his ACL out. He's a kicker. Don't celebrate. This is last year. Stephen Tulloch, sacking Aaron Rodgers, mimicked the discount double check maneuver, blew his ACL out. Boom. A week later, Lamar Houston of the Chicago Bears does a little bit of celebration of his own. Does the same thing, although he went down a lot more gracefully and looks a lot more surprised by it. But notice that all of those ended up with people jumping and landing, right? That force transfer to the ACL is most in that move. Okay, so over the last 10 years, participation by both genders has increased. The annual number of ACL injuries has been roughly similar, around the 200,000. So if there's more people playing and there's the same number of ACL injuries, it says a couple different things. And we know that in the less than 18-year-old group, ACL injuries are increasing. So it means that your elite and professional athletes are doing a better job at not getting injured. So it means they're training better, they're prophylaxing better, okay? It means that in your young kids, you're better aware. Your coaches, your players, your trainers, your athletes are better aware and they're ending up diagnosed more. It also, unfortunately, may mean that they're putting themselves at higher risk younger. Maybe this goes into the argument that kids are playing one sport versus all sports now, and they're not training in a well-rounded manner, and they're not developing correctly. Who knows? They're all doing studies on that, so we'll see how that plays out. So let's talk a little bit of anatomy. The knee itself, I'd like to introduce you to it. It's two joints, the patellofemoral joint and the tibiofemoral joint. We're really not going to talk much about the patellofemoral, although understand that it does play a role in ACL protection because it does help limit anterior translation of tibia when you land, and therefore it limits kind of as a helping antagonist to the stress placed on the ACL. But we're going to talk mostly about the tibiofemoral, and we'll talk more about all those stresses here in a second. So the tibiofemoral joint is the largest synovial joint in the body. It's a bicondylar modified hinge joint. Lateral medial condyle onto the tibial plateau. The lateral, right, is the fibula. So let's talk a little bit about the articulations. The tibiofemoral joint is a femoral articular surface, which is composed of the two large femoral condyles. They're separated by the intercondylar notch. This is important because in this intercondylar notch is where the ACL and the PCL originate. We're looking at it from posterior, and you can see how they come off. So you can see that the ACL comes off the lateral epicondyle or condyle, and you can see that the PCL comes off the medial condyle. Okay, but they track. So when your knee bends, they track in this little groove, which helps in aligning your knee, which helps in kind of moving your center of gravity through your knee. It also provides some risk to the ligaments because the ligaments are constrained in that groove. The articular surface of the tibia, two kind of shallow recesses on the tibial plateau that can coincide with the femoral condyles. That's what allows you to have that hinge motion. What you don't see here are the meniscus that are built up here that kind of allow you to build that cup that each mini joint articulates in. You can see that in between the two kind of recesses is this little ridge, this little mountain that's a tibia eminence. That's important because that plays a role in where the PCL and the ACL attach in the center of mechanics from control of the tibia standpoint. It's just a view of the meniscus as they kind of from above, kind of creating a cup for the joints to sit in. So let's talk a little bit about motion of the knee. The tibiofemoral joint has 6 degrees of motion: flexion, extension, external and internal rotation, varus and valgus rotation, anterior and posterior glide, medial and lateral shift, and compression and distraction. Okay, right? So it bends and it moves, and that's why we have all the things that keep the joint stable. That's why we need them, because we're going to hold it in that parameter. So how does it move? So it's a modified hinge joint, as I mentioned. So it doesn't just open and close, right? It's a combination movement. It rolls and it glides. So the rolling part is the hinge part. It does, as your condyles move in those recesses of the tibia, it moves. But because of the way our bodies are, it doesn't just do that. It actually glides. So when they bend, the tibia comes underneath the knee and moves posterior on the femur. Okay? And that's going to be important because we're going to talk about how that changes how the ACL mechanics feel. All right, so we know how it moves. How do we keep it stable? It's kept stable by 2 different kind of factors: your dynamic stabilizers and your passive stabilizers. Your dynamic stabilizers are your contractile structures, so your muscles, quads, hamstrings, your triceps surae, which is your gastroc-soleus complex. The passive stabilizers are your non-contractiles: joint capsule, medial and lateral meniscus, and the 4 stabilizing ligaments. We're all in rehab. We know that if you strengthen the dynamic stabilizers, you relieve some of the pressure from the passive stabilizers. Let's talk about the ligaments. The medial collateral ligament, the lateral collateral ligament. They each originate from the femoral epicondyles, which are the areas of bone just above the condyles, and they move to the medial collateral, comes down and starts on the tibia, provides a medial border. The lateral collateral comes down and attaches on the fibula, providing a lateral border, helping with lateral shift, helping with varus and valgus, helping with the support of that structure there. These folks here are not just praying that you're talking to me or that you're listening to me here. They're actually giving you a nice little mnemonic for the ACL. So if you cross your fingers, right, and then put your fingers over your knee, you can kind of see how your ACL and your PCL cross in your leg. You can kind of remember that's how they move from posterior to anterior, lateral and medial, and vice versa. So moving on to the ACL, the cruciate ligaments. Cruciate is Latin for cross, crucifix, right? So, and they're called that because that's literally what they do. They cross each other in that center of the knee. The ACL goes from the medial border of the lateral condyle. We showed that in a picture earlier. It moves inferior, anterior, and medial, and attaches to the anterior aspect of the tibial eminence. It blends there with the fibers of the medial meniscus, which is why when you injure your ACL, you're at such a high likelihood of having a concomitant medial meniscus injury. The posterior cruciate ligament comes from the medial border of the medial condyle, moves inferior, posterior, and lateral, and attaches on the posterior lateral aspect of the tibial plateau. Okay? So again, the mnemonic really helps in your mind if you want to play that out. So a little bit about the ACL. It provides approximately 85% of total passive restraining force of tibial anterior translation. Okay, so that landing moment where you land and your tibia wants to shoot out forward, that's done primarily by your ACL, and that pressure, that stress, that strain is the primary factor, the primary cause in ACL injury. Along with the PCL and the anatomy, right, we talked about how they run in that intercondylar notch. They provide a central alignment of movement through the knee. And because they kind of are the focus of movement through the knee, they also get to bear the brunt of most of the forces that run through the knee, okay, in any direction, because they're the epicenter of focus of movement. So let's change our scope a little bit and not talk about just the general anatomy of the knee. Let's bring it down a little bit and talk about the anatomy of just the ACL. The ACL has two components, the anterior medial bundle, the posterior lateral bundle. They're named based on where they insert on the anterior plateau. Okay, so it's actually two components, and they're important because they actually have their function based in different positions of the knee. Okay, they both do the same thing roughly, but they function at different positions of the knee. So here are a couple of pictures. They both show the same thing. We'll talk about the top one. On the left-hand side there, you see a knee in full extension and the fibers of the two different bundles. And on the right, you see a knee in 90-degree flexion in the two different bundles, okay? So you'll notice that the posterior lateral bundle, looking at the left side of that, is tight in extension. It's shorter, it's thicker. And when the knee is in extension, it provides most of that resistive force for anterior translation. Its also primary function at the time is it holds rotation in check, but it does do the anterior translation. And this is important because when we test Lockman's, right, we know our two tests for the knee are the Lockman's and the anterior drawer. Lockman's is always done in a more extended knee, right? It's only a couple of degrees of flexion versus the anterior drawer, which is much more flexed. So in Lockman's, or in a modified Lockman's, you're actually testing more the posterior lateral bundle than you are the anterior medial bundle. So if you were to rupture just that portion, you'll end up with, when the knee is extended, more rotation about the knee and more anterior translation about the knee. The anterior medial bundle is tight in flexion. You can see that as it flexes, remember our gliding and rolling maneuver, right? As our knee flexes, the femoral attachment, the femoral origin site of the posterior lateral bundle moves anteriorly. Okay, right, as it comes through, it moves anteriorly, and what that does is it loosens that posterior lateral bundle, and it allows the anterior lateral or the anterior medial bundle to tighten. And what it does when the knee is in flexion is it stops anterior translation of that tibia. Okay? So if you blow that out, you have more anterior tibial translation, and this goes into talking about our testing, the anterior drawer. You're testing more of the anterior medial bundle fibers. So, we've gone over anatomy. Let's talk a little bit about limb mechanics and kinematics. That can be a very complex thing, so we're going to try to simplify it. We're going to use just one motion, just one maneuver, deceleration maneuver, which is going to be jumping or landing from a jump on a single limb. You can infer all the other kind of mechanics that apply to each joint on the other wrist maneuvers from that. They're roughly the same. There's more rotational forces, etc. But this is a good intro. And we'll obviously understand that when anybody moves, right, our bodies move in multiplanar, dynamic, ways, and all of our joints and everything moves simultaneously. But instead of looking through everything simultaneously, we're going to simplify it and look at it kind of one joint at a time. So let's look at the knee joint first, the sagittal plane. In normal, this is all going to be normal individuals right now. So when you jump and land in a normal person, you're landing with your knee slightly flexed. Right? Your center of mass is behind your knee. You have a flexion moment. You have a huge anterior force pushing that tibia forward. All right? And so your knee wants to flex. Your body wants to collapse like an accordion. There's also a step-lat force pushing the tibia up into the femur. Doing kind of a compression force there, but that anterior translation force is, again, the most important force for us. So what checks that? What keeps that from collapsing, okay? So you've got your quadriceps and your hamstrings. Your quadriceps, they shorten, and what do? They extend the knee, right? So when they extend the knee, when you're landing, they actually resist that flexion moment. So they pull you back. The hamstrings, okay, they do roughly the same thing, which is weird because hamstrings, they normally flex the knee. They don't extend the knee. So why does this work? It's because when you land, you're in a closed chain system. Your foot can't move on the ground because friction's too high, right? So when it contracts, it doesn't flex the knee because it can't flex the knee. It actually pulls that knee posteriorly, okay? So it also is an antagonist. It works as a synergist with the quads but it works as an antagonist to that anterior force that you're feeling on the ACL, because it's posterior. So what we're going to think, yeah, we're going to have a little fun right now because this is new technology. Check me out. So here's two knees, all right? Here is going to be your quad. Here is your hamstring, okay? In your quad, you've got the vector of force, right? You already know you're moving that anterior force. You've got a higher, right? The vector force is, the biggest vector is right here. That gives a vertical force and a small posterior force. In the hamstring, that vector is already bigger this way. So you've already got a bigger posterior force, a smaller vertical force. So if you're having to say, okay, which muscle group is the most effective at slowing anterior translation of my knee, right? Which is it the hamstrings or the quadriceps? It's the hamstrings, right? And the physics has made it simple and easy, right? So it's obvious. So that's important because, as you'll find out, that plays a huge role. So let's move on to the coronal plane. The joint in a normal, healthy individual experiences a valgus moment at the knee as well, medial force load. It's not dynamically stabilized by muscles like the quads and the hamstrings are and how they work in the sagittal plane, right? So they're acted on by somewhere else, and they're actually not acted on the muscles. The coronal plane of the knee, the forces there aren't acted on by muscles at the knee. They're acted on by muscles at the hip and by movements that occur at the ankle. We'll talk about those. We're missing the slide that will talk about those. So we're going to just use our imagination to talk about those. So when we jump and when we land, we'll talk about the hip. When we land, our hip is in a flexion moment too, okay? Our hip wants to collapse. We want to come into this moment and collapse like an accordion. What keeps us from doing that, what keeps us in check from doing that is our gluteus maximus, right? That fires to extend our hip to keep us from collapsing. What it does, because it can't extend the knee, because again, our foot is attached to the ground in this moment, is it pulls on the back of the femur. Again, further adding a posterior vector and decreasing the amount of strain felt by the ACL. Okay, so that's important. From a coronal plane, when you land, your hip feels a lateral force and a valgus and a varus moment, right? Because you've got one leg's in swing still, so you want to collapse. Your leg is a little adducted naturally because that's just the way our skeletons are made up, so it wants to push out further laterally. So what fires? Your hip abductors, right? Your most important hip abductor is your glute medius. Okay, and those two muscles then, the maximus and the medius, are important, as we'll see pretty soon in the way things work. So normally, because of the way these muscles work and because of the fact that your ankle inverts when you're in contact, as your arch collapses and your ankle rolls over a little bit, your tibia internally rotates, and your knee has to move medial valgus to compensate for that, and because your skeleton already has an internally rotated femur, you know, to some degree, and already has an adducted femur to some degree, you end up with this normal motion, okay? Guys are a little bit different because we're a little bit stronger, and we'll see this later. But we have a little bit less valgus than women do naturally, but we have a natural valgus at the knee, a natural valgus moment. This is just the same example in a different, you know, just looking at bones instead of a leg. All right, so we understand kind of around the kinematics now, and we understand the anatomy a little bit better. Let's talk about why then the ACL gets screwed up. So there are 4 broad categories of risk. They've been researched pretty heavily, and the studies are pretty crappy. There's poor controls, so they're not well founded, but we use them anyway because they're the most proven. The 4 broad categories: environmental, anatomic, hormonal, and biomechanical. The environmental is primarily from these issues up here, which is the sport you play, right? That's the biggest factor. If a sport is one of those sports that puts you at the highest risk because your necessity to use the high-risk maneuvers, that's going to be a huge risk factor, okay? So that's probably the most easily modifiable of all of them. They initially thought play surface was a big deal, and so they did all these studies on wet surfaces, dry surfaces, hard surfaces, soft surfaces, old surfaces, new surfaces, and it was kind of inconclusive. They saw some data that said, well, maybe wet floors hurt the ACL less, dry floors hurt the ACL more. And that brought them into a theory of friction. And they're like, oh, well, in any situation where a foot contacts the ground, you have to have the foot contacting the ground. So what is it? And friction. And as it turns out, friction does have a relationship to ACL injury. Higher friction, higher risk of ACL injury. So gymnastics on a wet floor, no ACL injuries. Brain injuries, back injuries, neck injuries, right? Sure. ACL on a dry, gymnastics on a dry floor, they're sticking the landing, and there's a lot of forces, and their feet aren't moving, a lot of risk for ACL. Cleats in football actually put ACL at risk. They know that. But you can't cut and get past a guy, right, if you can't plant in the ground. And you're going to blow out your hip if you can't plant, you know. So it's all production versus risk, right? And for the ACL specifically, cleats are maybe a bad thing.
Do you see anything on turf versus grass?
It all depends, again, on the friction interface. So tennis shoes and turf, roughly similar to cleats, longer cleats and grass. But if you get into grass and wet conditions with less friction, you know, it goes back and forth. In general, there's not much difference. For knee injuries, a lot more rub burns and lacerations on the turf stuff. External knee brace use. In the 1970s, they came out and said, hey, wear these braces, it'll protect your knee. You see athletes of all levels wearing them still. 1984, after doing a whole lot of studies, the American Academy of Orthopedic Surgeons released a position statement that said they don't do squat, okay? Wear them if you want to, but they're not doing anything. Studies have since shown that they actually may put your ligaments at a little higher risk. It's more likely because of psychological factors, because when you're wearing the knee brace, you feel a little bit more invincible. It's like wearing a helmet, you feel a little bit more invincible. You still end up with concussions, right? So with the knee brace, proprioceptively, athletes like it. Psychologically, they like it. Doesn't do anything for protection. Any of them. Neoprene, your static hinge braces, your Bledsoe braces, any that you see this guy's wearing in the in NFL or otherwise. The theory is that if they protect anything, they protect the lateral ligaments a little bit more, but the data really shows that they don't actually protect. Right. And even the data is showing that with the force loads they're putting on their knees, it's not doing much for the collateral ligaments either. It's not putting them at higher risk, but it's not a whole lot different. So players continue to wear them because they feel like they like it, or their coaches are making them wear it, right? And you know, and who knows? But it hasn't shown anything. And again, these studies are they're good, but they're not great. So there's still a lot we don't know because we can't control a lot of these factors. So the next couple of risk factors, the groups of risk factors, they all kind of boil down to gender relationship. And so I'm not going to talk about them specifically. I've kind of created 4 new categories, kind of put them all together, that are based on gender. Quadricep dominance and deceleration in females, gluteus maximus and medius insufficiency in females, Q angle and valgus angulation increase in females, and estrogen, you know, the female sex hormone. So we're going to talk about those real quick. Quadriceps dominant deceleration. So what that refers to is the muscle complex that is preferentially used to slow that anterior deceleration, or that anterior translation by decelerating the limb, okay? In women, they're quadricep dominant. Their quadriceps fire first, they remain active longer, okay, than their hamstrings. In men, it's the exact opposite. Our hamstrings fire first, and they remain active longer. Okay, so remember when we were talking about our force vectors earlier, having to choose one muscle versus the other? We're actually neuromuscularly pre-programmed to land differently than females. Our muscles are actually protecting us in a pre-programmed landing sequence differently than female musculature is. And that's interesting. And they went further on and made a hamstring to quadricep ratio, the HQ ratio. And what that basically does is it just shows muscle use activity of one versus the other. Men have a 5 times higher HQ ratio than females. Okay. So what this equates to in this neuromuscular pre-programming, when we're in the air and these muscles, they both fire in both of our sexes before we land. Right? They're already active. So When we fire our hamstrings first, what are we doing in open chain, right? What's that do to the knee? Does it extend or flex? It flexes, right? They fire quadriceps first. Ladies, are you extending or flexing your knee in open chain with quadriceps? You're extending your knee, exactly. So when you land in a pre-programmed model, guys are landing with a more flexion in their knee, more activity in their hamstrings. Women are landing in a more straight-legged posture because they've got the higher quadricep activity. We talk about our vectors and bring it back to that physics point, but when you land, all that force is trying to battle that anterior motion. The hamstrings are a much better muscle to help that.
Sorry, just one quick question. Was these studies in regular people or in high-level athletes? So these females that they're testing was even high-level athletes.
It includes high-level athletes. These giant meta-analysis studies were done on a broad range, but we'll see. We'll get into that later. How training makes a difference to some degree. We'll talk about that. So we land differently. Okay. So again, this is just another kind of reminder, right, of how those hamstrings, if we're just focusing on the hamstrings, how they function differently in men and female. Okay. So you're doing less work in the knee in the female. And interesting, the male semimembranosus, one of the hamstring muscles, it fires later than all the other hamstring muscles. Okay. So not only do our hamstrings fire first and then our quads fire, but our semimembranosus waits. And then right before we make initial contact, it sets off like a lightning bolt. And what that does, because it's this muscle that hasn't contracted yet, and it contracts with such force that it has this peak to velocity or peak to velocity to peak force of that particular muscle is so short that it provides a huge posterior vector, right? And that happens at the same time that we're about to place that load on our ACL going forward. This semimembranosus doesn't wait in women. It fires along with all the other hamstrings when all the other hamstrings come in. So they don't have that same effect. So EMG studies were done on all those to kind of prove those muscles and how they work. We did the same thing in the glute maximus with medius. Basically showed that women, unfortunately, have a deficiency in neuromuscular control of both those muscle groups as well. They have a decreased activity level and strength in their gluteus maximus, so they don't have that extension right at the hip. They don't have that close change posterior pull on the femur as effectively. And regarding their medius, it fires later and it fires shorter than in men, which is important because in our the trendellator gauge to stabilize the pelvis, to affect that lateral varus moment at the hip, which we know affects the knee, puts more stress on that ACL. Skeletal differences in the Q angle in women and men. Women, we know, have larger, broader pelvises because they do us gentlemen the amazing gift of delivering children's for us. But we have to be set up a little bit differently because of that. As such, they've got a little bit more natural adduction of the femur. They have a little bit more femoral anteversion in the femoral acetabular joint, which is the internal rotation of the femurs. And that puts them naturally at a more valgus force load at the knee. Valgus force, as we've seen, is also a huge issue with ACL stress and strain. Okay, because that's one of the directions that the ACL protects against. It's not as important, turns out, as that anterior force load, that anterior tibial translation, but it's important. So moving on to estrogen effects. Prepubescent boys and girls, they've done studies. They show very little neuromuscular difference. Okay, so this is interesting. Their HQ ratio, similar. Their knee flexion when they land, similar. So what changes? Okay, why? What changes? And the reality is at the onset of puberty and throughout that pubertal growth spurt, everything changes. All right, so they've done studies now that show that women who have their pubertal growth spurt at that Tanner stage 2-3 sexual development stages, right, at around 11, 12 years old, they hit a peak velocity, high velocity growth rate at 8 to 10 centimeters a year, and that happens early on in their puberty, right? They grow really fast. Girls are always taller than, right? You guys are all, have you watched middle school dances? right? Girls are always at a foot and a half taller. Maybe, yeah. Not just middle school. Yeah. So, estrogen in women goes right away and it affects growth almost immediately. And it affects mostly the long bones. So in the lower limbs, these legs grow. Legs grow in the bones far faster than the surrounding and supporting musculature grows. In men, we hit puberty at around the same time, a little bit later, but we don't grow right away. That testosterone comes in and starts developing our muscles immediately. We get stronger first, and then we get taller. So when we grow, our muscles and our bones grow together. They grow more balanced. And we can prove this because we've done those same studies that we did on the prepubescents and that we've already done on the adults in the EMG and the kinematic and force studies, and we've seen that at near end-stage pubertal adolescents, their HQ ratio is approaching that of an adult. Okay, so within that window of puberty, things have changed. Their knee flexion ratio, or the knee flexion moment, they land with a straighter knee, just like adults do at the end of that year, at the end of their puberty stages. Okay, so everything changed there, and we know that guys don't have that. So, how does estrogen affect the ACL alone? In 1996, they found receptors on it, and they said, okay, well then maybe estrogen has an effect on the material structure of the ACL, or the integrity of the ACL. And they started doing a ton of research based on that. And sure enough, it certainly does. Estrogen decreases fibroblasts. Fibroblasts create collagen. Our ACL is primarily composed of collagen. It's the primary tensile load-bearing structure of our ACL. Type 1 collagen, type 3 collagen. Fibroblasts produce both. Estrogen decreases proliferation of fibroblasts. It decreases both. And they've proved this, both in lab studies and in tensile loading structure, in tensile loading studies. So this pig ACL study, they did a cyclic loading on an ACL, and they found that an ACL in an estrogen-free environment had because of the little damaging that occurs with that tensile loading over and over and over again, it built up. It laid down new collagen, new material. They bathed it in estrogen, they did the same thing, and they showed a decreased number of decreased proliferation, decreased collagen, decreased tensile strength.
Does it matter if it's endogenous or exogenous? Like if they're taking it or not?
I didn't read anything about that. Most of the stuff I read about was all based on endogenous. But we'll get into a little bit of that in a second. So this is all endogenous issues. So long term, if that's the case, if we know that long-term estrogen exposure decreases ACL strength, how does that change in, say, the menstrual cycle, where you have these short-term bursts of estrogen and short-term hormonal change? Well, they've done the studies, or they've done some preliminary studies, and the study isn't so good. But the best study we had was done on a group of intercollegiate athletes throughout a season, and it showed that, and again, this is non-validated, really, but it showed that women had a higher risk of ACL injury, that they actually had more ACLs during the ovulatory phase of their menstrual cycle, where estrogen surges, versus a significantly lower number during the follicular phase when they have estrogen and progesterone at a low. Interesting, right? I don't know. I mean, again, this is not something I'd say run out and tell your girls not to play during their cycle. You shouldn't take games off because of this or otherwise. But maybe you should. I don't know. We'll find out, right, as research goes. So if that's the case, could oral contraceptives, could they be protective, right? Could you do something to mediate that? Research says maybe, but we don't really know. And I wasn't going to present. There wasn't even a good enough study to prove otherwise. So I wasn't going to really present that. Theoretically, yes. So you've got an injured ACL, right? Understanding how and why it injures itself doesn't really do anything if you don't really understand kind of the next stages, the next part of treatment. So we're going to quickly roll through that. Outside of standard acute management, rest, ice, compression, elevation, there remains considerable debate on whether non-operative or operative measures are the correct way of treating an ACL post-rupture. In all cases, the overriding goal of ACL deficiency is to prevent further injury. Some of these further injuries can be chondral, right? Chondral damage, further meniscal tears, further ligamentous injuries, laxity of secondary constraints, excess laxity of collaterals that are there, ligaments that are there, and long-term degenerative changes that can affect the bone and the cartilage of the joint itself. So once ACL deficiency is diagnosed, they kind of at this point use an algorithm to decide whether or not the patient needs a non-operative treatment or an operative treatment. Currently, most people just get the operative treatment. And they kind of go through these variables. So patients age, younger, healthier individuals, more likely to get back to playing sports, they're going to say, hey, operate on it. At the age of 50 right now, they're saying, like, hey, if you're really active, get it operated on. But if you're not that active, see what happens if you don't get it fixed. And if your knee feels sucky, then go ahead and get it fixed, right? So it's still very much a surgical field. If you have any knee instability, if you feel like you can't do anything on it, right, get it fixed, because that's not going to fix itself. If you have any other meniscal or ligamentous injury, in order to prevent further damage, like we talked about, get it operated on. If you're able or willingness and ability to participate in rehabilitation, post-surgery, or maybe even pre-surgery, that might affect your decision. You just say, hey, screw it, go sit in the wheelchair, you're done. Don't do anything. But if they're going to really participate, then surgery might be the best option. And then, of course, whether or not they want to get back to full, when they want to get back, they want to get back sooner, they want to get back later. Are they okay with not being as active as they were initially? Do they have to return to the Minnesota Vikings to win a bunch of awards and then get arrested for child abuse? Right? So overall, though, there's very little difference in the treatment algorithm between partial tears and complete ruptures. Will a partial ACL tear heal? Kind of, sort of, not really. Fibroblasts, scar tissue, fibrotic scar tissue fills in that gap. You'll hear people say on MRI, evidence of a healed ACL, but that's just different tissue laid down to fill that gap. It's not strong tissue. The tensile strength is much less. So without repairing that ACL, you're not going to have that same integrity. So, and then the difference between repair and reconstruction, real quick. So repair is me sewing that native ACL back together. It doesn't work. That was what they tried first. There's not enough growth factors there to keep it alive, so it dies off. So they kind of abandoned that, and they went towards a reconstructive, right, primarily, which is the gold standard currently for surgery. And in reconstruction, they remove your ACL, and they put in a autogenous graft from you, either from your Achilles, from your hamstrings, from your patella, right? And they put that in there, or they use a cadaver tissue, or they've played with some synthetic ideas, but honestly, they're not very good, so we're not even going to talk about them. So the Allograft, the self-donor, it's the most commonly used. It provides an autogenous framework for revascularization and healing. It heals faster than Allograft because it's your tissue and because it's already got all your cells. It's a more complicated surgery, though, because they're actually harvesting from somewhere else, too. So now you've got two things to worry about. So there are two big ones. There's the patellar ligament bone graft, where they take from your patella plug and from your tibial apophysis, a plug and connected by the ligament there, and they place that into the knee, sew it up. Okay, it's thick, it's stable, it's strong. Most people like it because it feels like it gives them a really stiff, stable knee, but it is really stiff, so it's not as functional as an ACL. Okay. The other option is the hamstring graft, the tendon graft, which we see here. That's the second most commonly used, and that's when they pull a portion of your gracilis and your semitendinosus, and they kind of wrap them up, and then they place them in that same kind of knee, tied in. Okay, it provides the outcomes are relatively similar between both tendons. It gives a little bit more movement, feels a little bit more like a natural ACL, so some people like that, but it's still not your ACL. So allograft, the cadaver donors, It heals slower because it's a foreign tissue. It's a dead tissue, right? It's not going to have all your cells and everything there involved. But it's an easier surgery. You're not harvesting from anywhere. It's a quicker surgery, so surgical time is a big issue for you. Than do it. Cosmetically, it doesn't provide a huge anterior scar like the anterior patellar bone graft does, so it looks better. Okay. Going back to the hamstring graft, they use that more in kids than they do the patellar bone plug because they take that plug from the tibial apophysis, and in a skeletally immature child, that may affect bone growth. So they take it from the tendon, and right now they use that. But the pro of the cadaver tissue is that you can just keep getting it. There's a lot of folks that have unfortunately passed on that have nice ligaments, so you can keep taking it. You can keep putting that in. So if you're going to be a person that gets re-injured over and over again and knows it, it's a good one to use. You can keep going through surgeries for it, and it doesn't have any of the harvesting site complications because there is no harvest site. From regards to non-operative treatment, rehabilitation and strengthening, dynamic strengthening of the dynamic stabilizers is the kind of the regimen. They've tried doing a whole lot of studies on this too to see how effective that is, but unfortunately there are a couple limitations to that. One is that most healthy, young, active individuals want to get back to doing what they were doing faster, so they opt for surgery right away. The other thing is that even those that go, oh yeah, I'll try it out, let's see what happens, they get up, they can move it around, they go, my knee feels like crap, I want to go do the surgery, and they back out of the study and go ahead and do the surgery. Okay, it works. There's no correct treatment option. It is all based on your needs specifically, each athlete. So that's the standard of care now. We're going to talk a little bit about kind of the future, where things can go there. Some novel biological ACL repair approaches, and this is cool because remember with the repair I talked about was what they had tried, but it wasn't working, or it was failing, so they moved to that reconstruction. If they can find a way to get the repair to work, the repair provides a lot of benefits that the reconstructions don't. The native insertion site, proprioceptive function of your ACL, that's not removed because you still have your ACL, right? So that is all still there. Joint mechanics, because the proprioception and all the insertion sites, that's all still there. That's all still your body, your mechanics. And of course, there's less operation, right? Because you're not harvesting, you're not digging around, you're just kind of going in and sewing it up. But we know that doesn't work, right? So how do we make that work? And so they've come up with other kind of adjuvants to help with it. We got stem cells, gene transfer therapy, growth factor therapy, including PRP, bioactive scaffolds. This, we'll talk about, this is the most exciting thing to happen in ACLs in a very, very long time, and it's actively emerging right now. So stem cells, they're totipotent, right? They can turn into anything. Fibroblasts, which would be great because they turn into collagen, and they've shown that in studies that alone they provide more histological normalcy than do ACLs without it, right? So you're not getting that fibrotic scar tissue, you're actually laying down good tissue. In studies of reconstruction plus stem cells, they've showed a big time increase in biomechanics of the knee, right, and the healing factors, so that's great. But we don't know how to turn stem cells into fibroblasts. We still don't know how to turn on what switches and key what proteins to do what thing here, so we could just, you grow ears in your knee for all you know, right? So that's still limited. Gene transfer therapy, they've talked a lot about this recently in the news with cancers and delivering, changing the way genes are expressed based on viral, non-viral vectors, non-infectious vectors, by getting in at the mRNA level and changing things. And this has shown some success in ex vivo and in vivo studies as well. Growth factor is gaining traction. We've known about these growth factors for a long time, but we're kind of putting that into places now to see how they activate and how they work. And they are working. They're showing better deposition of extracellular matrices. They're showing better transitions of those totipotent stem cells into fibroblasts based on individual growth factors and finding the things that kind of make them turn into the cells we want them to turn into. Includes platelet-rich plasma, which we know, studies are mixed on. I like it, right? It separates your platelets out from your autologous blood, right? and your platelets are full of growth factors. And when they degranulate in the area of injury, because platelets are the first thing to get to somewhere that's hurt, you bathe this area in these growth factors and theoretically stimulate healing, right, through both the inflammatory and the healing phases. So, but more importantly, what I want to focus on a little bit more is this bioactive scaffold. So this is brand new. This is they've been studying this over the last couple of years. They actually just released a paper early this year that talks about the benefits of this. So what it is it based on a theory that why weren't repairs working? And the repairs weren't working not because they didn't have the right mediators of healing, right? Not because the certain growth factors that your endogenous growth factors weren't showing up to the areas, that they didn't have a scaffold to climb. They didn't have a scaffold to repair itself. So all this is they developed this gel matrix scaffold, right? So that along with surgery, they put in this gel matrix scaffold, surround this repair, and they're showing great results. Right? So this 2015 study showed a large animal randomized trial that showed that enhanced scaffold ACL repair was equal in outcome to reconstruction, which as it is currently our gold standard. So this could change everything about ACL reconstruction. Here is a schematic showing the difference. The red is the ACL reconstruction. The paler color is the repair with the scaffold, and then the white is the no treatment. And you can see that in yield load, max load, and linear stiffness, they're comparable. They're not statistically significantly different, but they're comparable between the two. So another thing, and maybe the most important thing, is right now, if you get a reconstruction, in a year from now, you're guaranteed almost to have osteoarthritis, which is that degenerative change that we're all worried about. So if you screw up your ACL now, how are you going to feel when you're 70, right? How's that going to progress? 80% of people 1 year out have some degree of osteoarthritis after reconstruction. 1 year out in the scaffold repair, no arthritis, which is huge. Okay, that long-term degenerative change, that risk may not be there. Here's a picture from that study earlier this year that shows no treatment 1 year. You can see all that horrible breakdown because of all the instability in the knee and all the grinding you're doing in the knee. The middle picture is 1 year post-reconstruction. You can see that there is some decent amount of breakdown there where that arrow is. And then the 1 year post-scaffold repair. Clean, smooth, shiny, healthy. So again, this could flip the ACL surgical world and potentially the rehab world after that on its head. Right? It could see our time, that 6 to 8 months, which is our average, really shorten up, which would be great for getting people back out into play. So, speaking of getting people back out and play, you hear this all the time. Part for us is when can I get back to play? When can I get in? And the answer is there's no exact timeline. I can't say, hey, 6 to 8 months. Okay, there's a protocol that everyone has to go through that's based on meeting criteria and meeting goals. There's an average time that everybody has, but it's really individually specific, person to person. 5 phases in general. There's actually a 6th phase, which has kind of become the gold standard of therapy also. It's called prehab. Rehabilitation has been shown to get people back post-operatively sooner than without it, and all that does is really it optimizes the infected knee by giving it time to for the pain mediators to decrease, for the swelling to decrease, for the soft tissue around the knee to heal a little bit before you go in and do surgery. It also allows you time to maximize the proprioception on that affected knee, kind of see what you still have intact, and take care of that unaffected contralateral knee too. Strengthen that, get that better conditioned, increase the endurance there, getting you ready for surgery and therapy. Okay, but we'll talk about each of these 5 phases really quick. The immediate post-op phase, the whole goal here is to increase range of motion and to keep the knee healthy. Okay, so between 2 weeks, you want to be from 0 to 90 degrees. You can do things like extension bridges, prone hangs, which is just kind of passive range of motion through the knee. You want to initiate and establish quadriceps function. You want to get that activated again. And the goal here before moving on to phase 2 is that you want to be able to do a straight leg raise without extension lag, meaning that when you activate your quad and pull your heel up off the bed, Then when you do it, it comes up straight, and you're not bending at the knee first and then kind of having to fire out that extension of the knee. All right, so you don't want that lag. You want to return to walking without assistive device and using normal gait mechanics. You'll see people, because their ACLs are weak at the time, they'll avoid that ACL, so they won't flex. They'll hip hike, they'll circumduct, they'll do all those things that we know about from our gait stuff. And then, of course, it's post-op, so you want to make sure that you're taking care of the post-operative stuff, rest, ice, compression, elevation. That all help with wound healing. So moving on to phase 2, you're increasing your range of motion. You're adding the wall and heel slide, which now adds an element of friction into that ranging that you're doing. You're starting kind of close change functional exercises at this point. A stationary bicycle, mini squats, mini lunges, all within a kind of a protracted range of motion, right? And then progressing as you get stronger with it. You want to start working on core stability, your calf raises, things that dynamically function around the ankle and around the hip that affect the knee we talked about earlier. So the emphasis here is on VMO control, core stability, avoiding varus and valgus mechanisms while strengthening those hamstrings and quads. You start working on your balance and proprioception, one leg, static limb balances, eyes open, eyes closed. If you haven't done that, try that. It makes it so much harder when you close your eyes. You take away that. You kind of mentally disturb it. Change the surface. Don't just stand on, after you're good at that, add a pad underneath. Gives you a little bit more instability in the ankle. It'll give a lot more movement through the knee. And you have to be able to go up and down stairs with normal step mechanics. Okay? Once you're at that, you hit phase 3. Phase 3, your advanced rehab activities. The whole goal of this period of time is to really ameliorate the strength differences between each leg. It's to get your affected leg back to about equal as your good leg. And so you continue the same things you've been doing. You continue the stretching, the range of motions. You add other mental perturbation tasks, distraction tasks. So you work more on your balance, you work more on your proprioception. You get into multi-plane strengthening, your squats, with reaches, right, in all your directions there to create multi-planar exercises on each. And at this point, you really want to start restoring the neuromuscular control mechanisms, right? So the firing of all the groups together, one or the other. So you start working on progressive skipping, progressive jump, takeoff, landings towards the end of that, because again, they're still minor in their force load and in their angulation of the knee. Once there, move on to the next, which is your advanced functional activities. This is really getting you back to kind of more your sport-specific needs. Increasing as you go in their ladder drills, jogging. Once you hit 75% of your speed, you can get into some cutting and some high-speed running stuff. Some more jumping, more force-loading activities. Start with double leg, right? So you're dispersing the force and move on to your single leg as your leg gets stronger. Once you've hit all these, you move on to the 5th phase, which is your return to sport. The key here is that the athlete has to feel confident. And the trainers, physicians, coaches, and everyone else involved has to make sure that the athlete isn't overconfident, and that everybody as a team decides if the athlete's ready to return to play. So let's talk about, we're almost done. We've got some outcomes. ACL deficient return to play. We talked about that ACL deficiency, so if they haven't had repair, they haven't had reconstruction, they have a 20 to 30% chance of returning to the level of play they were before. That is a skewed number, as I said, because a lot of those guys that jump out of that study, young, healthy, active people end up getting the surgery anyway, so that leaves you with your kind of less active, maybe non-athletes that have torn their ACL that don't really want to get back to that level. So that's kind of a flub number. But after ACL reconstruction, these are all good numbers. Greater than 90% of people return to full physical function in ADLs. 82% return to some form of sports play. 65 return to pre-injury participation level. 55 return to competitive elite professional levels. Okay, and the disparity between these is probably all psychological. All right, and who wants to return? If you need to return, do you want to return? I mean, I don't know. Any of you broken a limb? I blew up my ankle pretty good, and I still can't do things that I did because my mind goes, well, check yourself. You don't want to be on crutches again or undergo surgery again. So gets into some psychological factors that they're looking into, but they don't have any reason for yet. Men are more likely overall to return to play than women. Your chance of re-tearing the post-op ACL right now is 5 to 15%. It's higher. I couldn't find an actual number based on the people that go back into competitive level sports, right? But that'll make it a higher risk. But overall, in everybody, it's 5 to 15%. Interestingly, it's actually more likely that you tear your contralateral ACL than you do re-tear your bad ACL. And this is probably because during that rehabilitation phase, they didn't compensate right, or they overcompensated, and they didn't get back to their normal mechanics, and so they compensated and ended up screwing up their other leg. So how do you prevent it, right? So here's some theories on prevention. So they've actually done a good bit of study on this. Most of it's been based on how to prevent it in females because they do have such a higher risk than males, but a lot of this can be inferred to both sexes pretty easily. So meta-analysis do show that ACL injury risk is significantly decreased in females who participate in muscular training programs. Commonalities in these training programs are high-intensity jumping, plyometrics, biomechanic assessment, and direct feedback on positioning and their biomechanics and how they can fix those immediately, as well as a compliance in these programs for 6 weeks at least for your education. Core strengthening regimens also are shown to decrease injury. They weren't involved in every one of these regimens, but they have been shown, so they're a good addition. Balance training and strength training were involved in all of these, but individually, statistically, weren't significant in reducing ACL risk. They're great things for overall health and overall stability and everything else, but not necessarily for the ACL specifically. So we've done studies on this too. They've done these same neuromuscular kinetic EMG studies, and they've shown that females and early adolescents may benefit the most from these programs. In mid-teen, early pubescent females that undergo these neuromuscular training programs, they show a much larger response to the training than do your post-pubescent adult females, who also show training, who show effect of that training of changing the neuromuscular control. But again, we mentioned that, remember, in puberty, everything changes, and that's when that kind of nidus of change is. So if you can train throughout that period of time, you can significantly decrease the risk for ACL injury in the adult female. And a real-world example of this is dancers. They've done a good bit of study on dancers, and there's one big study, kind of the big study that they talk about with this. They look at dancers in that kind of active range. They tear their ACLs like crazy, right? I mean, we know that, because they're putting themselves at such high risk with all these maneuvers. But their incidence of ACL injury is actually much less than any of those incidences we saw earlier on in the discussion. Okay? So even though they do tear them, they tear it at a much lower rate. And the reason this is because they've been trained. Laboratory studies have showed that in high school and college dancers who undertake single limb drop landings are shown to have a higher HQ ratio, and are shown to have a higher degree of knee flexion on landing, about the same as an average age-matched male. Okay? Notably, that all these dancers that were studied were actively involved in dance during puberty. Okay? So they were involved in a neuromuscular training rehab, basically, that functions on jump, landings, and all those above during that formative stages of their years. So it may be good for both males and females, right? So get your girls in a dance, get your guys in a dance, right? Here are my these aren't my references. These are just cartoons making fun of Derrick Rose, which I thought was cool. Symbol that's really upset. So people are always just upset. But you can check my references out in my paper. Thank you. This is it. So, have you any questions, anybody?
What's the scaffold? You mentioned it, but what? Maybe I missed it. Stem cells or what?
Yeah, you got to pay attention. It's right. It's a gel matrix that's been infused with other components of the extracellular matrix. So it's basically the interstitial fibers that have been infused into a gel matrix that is placed around the repair surgery site.
So does it have fiberglass?
No, what it does is it allows, it's literally a scaffold. It allows your body's fiberglass to climb to where they need to be, which is something that hadn't happened before. Something they could have come up with years ago and just skip reconstruction together. It's very, I mean, it's very similar.
And going on your point of stem cells, nobody knows exactly how in order to differentiate whatever region you put it, but I think over the last 5 to 7 years, I don't think there's even case reports of any incidents of issues with stem cells used for skeletal issues, but I wonder if it goes along with bioactive that did talk as far as the environment that's been. That's how you know.
See anything on bracing during the rehab stage?
Same as before. It makes people feel better. Very little evidence that it actually does anything during the rehab phase. In general, braces come off at around the 2 to 4 week range post-op because you want to develop the dynamic stabilizers, right? That's the whole key. And if you put a brace on, it actually limits the amount of dynamic stabilization. So it's good for protecting varus and valgus movements initially, an extra strain on that limb, but that's kind of a surgeon-specific, patient-specific thing. Same as the risk factors for ACL bracing does very little.
Just about the environmental stuff. So is it safe to assume that ice hockey players don't get
I don't remember seeing anything on ice hockey. They have very little friction there, but they do have they do a lot of decelerating activities in the hockey stop when they turn laterally and put a lot of force on that limb. There's minimal jumping. There is some jumping, but I assume there's a reason that they didn't mention ice hockey in the NCAA sports at risk, because that's definitely a very popular NCAA sport.
So theoretically, if we play football on ice,
Less ACL,
a lot of these.
more neck injuries, more head injuries, more foosh injuries. Yeah. It'd be great. It'd be more fun to watch. Yeah.
Is there an ideal HQ ratio? Say,
No. The ideal HQ ratio is somewhere analogous to a general male-based HQ ratio. The idea being that you just want to focus on functionally training your hamstrings to fire first. And you can do that with unconscious and conscious training. I didn't talk about it here, but there are a lot of studies on where they had just training programs and then they did the mechanics after the training programs and showed that people were consciously landing with greater knee flexion and by proxy had to have greater hamstring and just body positioning. I know that kind of adds into the muscular training. But no, there wasn't a number. Just, the more similar they are, right, the better. The more close to 1 you are, the better you are.
When you do the matrix injection, is there a period of immobility, or is it like kind of what Randy was saying, consecutive with natural motion right from the get-go, kind of?
Yeah. Kind of one of our tenets,
encourages
right,
it to-
is move it almost immediately, right? The only reason that they don't like they kind of say this period of immobility with surgery is because they're worried about the wound, they're worried about the soft tissues around it, they're worried about the skin. Healing factors are stimulated with movement. They work faster with movement. You move the stuff that you injected around better with movement, so you spread it better. We know movement is good.
With the female athletes who don't have the ACL injuries or the athletes, were they at high risk for all injuries?
Like all ligamentous injuries. This was purely one based on ACL. They did in the introduction of that paper talk about the potential in that theory, but this was specifically built to look at the ACLs. because again, it's so hard. How do you control for that, right? I mean, it's why it's not a real great study. Is that they just kind of were like, okay, let's follow women and let's ask them when their periods are, and then let's see when they hurt their knees. And there was some significance, but I don't know. It was a poor study. That's where I live now. I'm just visiting the United States.
You look at drones.
No, this is a very expensive French photographer who I hired. She's actually from Ireland, which is weird, but she was not cheap. Just like everything else in the show.